Bom dia a todos. Olá, bom dia a todas e todos. Podemos começar? Ana Paula, tudo certo? Ok, então vamos dar... Pode falar, Ana Paula.
Tudo certo, professora, pode dar início.
Ok, então bom dia a todas e todos, é uma honra estar aqui, né, dando boas-vindas, né, a todas e todos nessa 9ª versão do Seminário Internacional de Saúde da Criança e do Adolescente, pela primeira vez uma versão online, e é uma honra para mim convidar as pessoas, né, as autoridades da Escola de Enfermagem Ana Nery, da Universidade Federal do Rio de Janeiro, para compor essa mesa de abertura do 9º Seminário Internacional de Saúde da Criança e do Adolescente. Então, eu peço a Ana Paula para que apareça aí do nosso estúdio, né, que seja liberado do estúdio, o professor Rafael Celestino, como coordenador de pós-graduação em enfermagem da Escola Ana Nery, e a professora Leão Ciufo, como chefe do Departamento de Enfermagem Materna Infantil e representando a direção da Escola de Enfermagem Ana Nery. Eu sou Ivone Evangelista Cabral e estou coordenando essa 9ª versão do Seminário Internacional de Saúde da Criança e do Adolescente. Então, eu passo a palavra agora ao professor Rafael, como chefe do departamento, uma vez que o 9º CISCA, carinhosamente chamada por todas e todos nós do grupo de pesquisa, dos 3 grupos de pesquisas do Núcleo de Pesquisa de Enfermagem em Saúde da Criança e do Adolescente. Então, convido aí o professor Rafael como coordenador da pós-graduação, evento este promovido pela pós-graduação, que ele faça as honras da abertura do evento.
Bom dia a todos. Inicialmente, gostaria de cumprimentar a professora doutora Ivone Evangelista Cabral, professora titular aposentada do Departamento de Enfermagem Materna Infantil, e nessa ocasião presidente, né, do 9º Seminário Internacional de Pesquisa em Saúde da Criança e do Adolescente, e também cumprimentar a professora Leão Ciufo, chefe do Departamento de Enfermagem Materna Infantil, em nome das quais eu cumprimento a todos os pesquisadores da área de saúde da criança e do adolescente da Escola de Enfermagem Ana Nery, assim como toda a plateia que está nos acompanhando aí através do canal do YouTube. Queria dizer, na qualidade de coordenador do Programa de Pós-Graduação Stricto Sensu em Enfermagem da Escola de Enfermagem Ana Nery, UFRJ, que é uma satisfação para a coordenação do programa poder estar apoiando a organização desse evento, desse 9º Seminário Internacional de Pesquisa em Saúde da Criança e do Adolescente, que é copromovido, na verdade, pela coordenação do Programa de Pós-Graduação Stricto Sensu, mas que é organizado pelos grupos de pesquisa Crianças com Necessidades Especiais de Saúde, que é o grupo CRIANES, pelo grupo de pesquisa, que é liderado, né, pelas professoras Ivone Evangelista Cabral e Juliana Rezende Montenegro de Moraes, pelo grupo de pesquisa Saúde da Criança, Cenário Hospitalar, liderado pelas professoras Isabel Cristina, né, dos Santos Oliveira, na condição agora de professora aposentada, em processo de transição, e a professora Tânia Vignuda de Souza, e pelo grupo de pesquisa Enfermagem em Saúde do Recém-Nascido e Sua Família, liderados pelas professoras Marialda Moreira Cristófalo e professora Elisa Rodrigues. Então, esse evento é uma alegria muito grande para a coordenação do programa poder estar contribuindo na sua organização, na sua copromoção, vamos dizer assim, e organizado aí pelos grupos de pesquisa, liderado por essas pesquisadoras, que são professoras permanentes do nosso programa de pós-graduação Stricto Sensu. Queria dizer que a linha de pesquisa Saúde da Criança e do Adolescente há bastante tempo é uma linha consolidada no nosso programa e vem contribuindo com a produção de conhecimento e a produção de evidências que tem sustentado o cuidado em saúde de enfermagem à criança e ao adolescente. E essa consolidação dessa linha de pesquisa ela vem sendo visualizada pela formação de recursos humanos, pela produção intelectual e pela formação de redes nacionais e internacionais. Então, quando a gente observa a programação do evento, que tem como tema central do evento os modelos de cuidado, né, baseados em evidência, a gente tem uma programação riquíssima, né, que traz diversas modalidades, vamos assim dizer, tanto baseado na ética do cuidado, quanto nas teorias de enfermagem, quanto nos modelos de cuidado desenvolvimental, e o modelo de promoção à saúde, que são atividades que vão acontecer ao longo da programação, coordenadas ou ministradas por diversos parceiros que há algum tempo vem mantendo parceria com os pesquisadores da área de saúde da criança e do adolescente, né, sejam eles nacionais ou internacionais. Então, a proposta do evento ele contribui para fomentar ainda mais essas redes nacionais e internacionais, e penso que a participação do público, a interação, ainda que no formato remoto, dará a possibilidade de trocas de saberes, experiências e de novos intercâmbios, de novas possibilidades de pesquisa. Então, eu agradeço a oportunidade de estar aqui fazendo a abertura em conjunto com as professoras, né, a professora Lia e a professora Ivone, e desejo que tenhamos todos um evento profícuo, né, que possamos aproveitar todas essas oportunidades que estão elencadas, que foram construídas com bastante cuidado pelos pesquisadores da Escola de Enfermagem na NERI e do Programa de Pós-Graduação no âmbito do 9º Seminário Internacional, e dizer que a coordenação do programa está à disposição, né, de todos aí os seus pesquisadores, estudantes, alunos de mestrado, doutorado, para apoiar, né, todas essas iniciativas que possibilitam essa troca de conhecimentos e, efetivamente, a produção de conhecimento e que impacte aí na promoção desse cuidado em saúde e de enfermagem à saúde da criança. Então, muito obrigado pela oportunidade e, mais uma vez, colocando a coordenação do programa à disposição aí na infraestrutura necessária à operacionalização do evento.
Muito obrigada, professor Rafael, pelas suas palavras e o seu acolhimento, né, do evento no programa de pós-graduação e o suporte, né, que o PROEX, né, e CAP está afirmando, né, e consolidando, né, esse seminário que acontece anualmente e promovido pelas diferentes grupos de pesquisas da linha de pesquisa em enfermagem e saúde da criança e do adolescente do programa de pós-graduação. Então, imediatamente eu passo a palavra à professora Lia, como chefe do departamento e representando a direção.
Primeiramente, gostaria de saudar os presentes com bom dia. Bom dia também, professora Ivone, coordenadora do evento. Bom dia, professor Rafael, coordenador da pós-graduação da Escola de Enfermagem na NERI. Eu sou Lia Leão Ciufo, estou como chefe do Departamento de Enfermagem Materna e Infantil e estou representando a direção da Escola de Enfermagem na NERI. Gostaria de justificar que a professora doutora Elizabeth Paz, a nossa diretora, está em atividade externa, e a nossa vice-diretora, professora Silvia Araújo, neste momento está numa abertura de banca de promoção titular docente. Nesse sentido, eu dou as boas-vindas aos participantes e expresso, em nome da direção, a satisfação da concretude desse evento. O Seminário Internacional de Pesquisa em Saúde da Criança e do Adolescente faz parte da construção da história da Escola de Enfermagem na NERI, que é uma escola de vanguarda, que é uma escola pioneira e traz como tema central a enfermagem em saúde do neonato, criança e adolescente e os modelos de cuidado baseado em evidência e boas práticas, possibilitando a discussão, a reflexão e, acima de tudo, o fortalecimento de pesquisas neste campo do conhecimento, tanto para a atenção primária, mas também no âmbito do cenário hospitalar. Então, nesse sentido, que eu desejo que esses 2 dias possam transcorrer de forma produtiva para todos e que possam aproveitar bastante, e agradeço a oportunidade de estar com vocês.
Muito obrigada, professora Lia, também por suas palavras e o reconhecimento, né, da construção desse seminário como parte da história da Escola de Enfermagem na NERI, da Universidade Federal do Rio de Janeiro. E nesse ano de 2022, como já foi bem dito pelo professor Rafael e a professora Lia, a comissão organizadora, né, está desenvolvendo esse tema da enfermagem em saúde do neonato, criança e adolescente, os modelos de cuidado baseados em evidências e boas práticas, pensando no desenvolvimento dos estudos e pesquisas e também na prática clínica. Eu agradeço às professoras doutoras Elisa da Conceição Rodrigues, Juliana Moraes, Tânia Vignuda de Souza, Marialda Moreira Cristófalo, Lia Leão Ciufo, Ana Letícia Gomes e a professora Renata Bobadué, pelo empenho e dedicação na organização desse evento. Nos dias de hoje e amanhã, os 490 inscritos de diferentes regiões do país terão a oportunidade de ouvir e interagir com os nossos palestrantes nacionais e internacionais, como inicia hoje, com a conferência de abertura, com o professor Dr. Franco Carnevale, que vai abordar sobre o modelo Childhood Ethics, nos cuidados e desenvolvimento de estudos e pesquisas com crianças e adolescentes, a teoria sistêmica de Beth Newman, nos cuidados e desenvolvimento de estudos e pesquisas com crianças, adolescentes e suas famílias, que vai ser essa palestra, né, essa conferência será proferida, né, pelas professoras Maria de Lourdes Lomba e a professora Márcia Pestana, né, da Universidade, né, da Escola Superior de Enfermagem de Coimbra e a Escola Superior de Enfermagem do Porto, o modelo de promoção da saúde no desenvolvimento de estudos e pesquisas com famílias de recém-nascidos, com a professora da Ana Linares, e um modelo de cuidado desenvolvimental nos estudos e pesquisas com recém-nascidos, que serão todos conduzidos pelo Grupo de Pesquisas de Enfermagem e Saúde do Neonato e Famílias. Os trabalhos serão apresentados na forma de sessões coordenadas, sessões que concorrem a prêmio, o prêmio Eusébio e o prêmio Laci Barreto, e totalizando 237 trabalhos científicos que serão expostos em sessões coordenadas e postas. Então, nós desejamos que vocês aproveitem esses espaços criados para interagir, fazer perguntas e registrar seus argumentos nos chats da plataforma e interagir com os nossos palestrantes. Um excelente evento para todas e um bom dia e um bom final de semana de quinta e sexta-feira para nós. Obrigada. Oi, Ana, pedi para a gente dar uma conversada com o Franco para explicar para ele como é que vai funcionar a dinâmica, tá bom? Você pode trazer ele para o estúdio. Bom dia novamente a todas e todos. Estamos retomando agora com o início da programação e esperamos que o público possa apreciar esse momento muito importante da organização do 9º Seminário Internacional de Saúde da Criança e do Adolescente, e que teremos como nosso conferencista nesta sessão, né, de abertura, né, conferência de abertura do 9º CISCA, o professor Dr. Franco Carnevale, a quem eu solicito que a Ana Paula traga do estúdio para o nosso público. Por favor, Ana Paula, poderia apresentar, né, o professor Franco? Muito obrigada, professor Franco. Thank you very much for your presence here with us once more. Professor Dr. Franco Carnevale é enfermeiro, bioeticista e psicólogo. Ele é professor titular de enfermagem da McGill University, Montreal, Canadá, e como pesquisador ele tem se dedicado ao desenvolvimento e aplicação do modelo teórico Childhood Ethics e defendido o reconhecimento da voz da criança e dos jovens, dos adolescentes e jovens, nas pesquisas sobre esse grupo humano, bem como a sua aplicação no campo dos cuidados clínicos. Na clínica, como bioeticista clínico, tem atuado como consultor em casos, como vocês poderão assistir, 2 casos na apresentação dele, que envolvem dilemas éticos no cuidado de crianças nas mais variadas condições de adoecimento em favor do melhor interesse da criança. Ele é autor de incontáveis artigos científicos e capítulos de livros sobre a ética na infância. Agora, vamos escutá-lo em sua preleção de 1 hora e depois o público aqui presente terá a oportunidade de fazer perguntas e ele estará ao vivo para respondê-los, tá? Me parece, Ana Paula, que aqui no chat está dizendo que a música de fundo está impedindo o grupo de escutar melhor. Você poderia retirar a música de fundo? Por favor, poderia retirar a música? Ok, obrigada. Então, eu vou só repetir as últimas palavras do currículo do professor Franco, que tem uma relação direta com o conteúdo da nossa apresentação de hoje, desta apresentação de hoje. Ele tem se dedicado no curso do tempo, né, como pesquisador e bioeticista clínico, não só no desenvolvimento de pesquisas sobre esse grupo humano, reconhecendo a voz da criança, né, do jovem e adolescente na tomada de decisão sobre os processos de investigar e processos de cuidar, né, no âmbito da clínica, mas também ele tem construído aí um modelo que tem nos auxiliado a repensar o lugar da criança nos cuidados e no desenvolvimento das pesquisas. Ele é autor de incontáveis artigos científicos e capítulos de livros sobre a ética na infância. Agora nós vamos escutá-los nessa preleção de 1 hora e depois vocês terão a oportunidade de fazer perguntas e ele estará ao vivo aqui para respondê-las. Enquanto o público faz as perguntas, né, eu peço para vocês, podem escrever as suas perguntas em português. Nós estamos aqui no backstage, a Renata também, a Renata Bubadoé está conosco aqui nos ajudando nessa tarefa. A gente pode estar convertendo as perguntas de vocês do inglês para o português e ele poderá responder, tá bom? Então, Franco, I just finished to introduce you to the audience, and then we project your video, and then the public, after 1 hour, we can hear from you the answer of the question that can set here at the chat on YouTube, okay? So,
obrigado.
Oh, thank you. Ana, você pode compartilhar o vídeo, por favor, do professor Franco?
I'm Franco Carnevale, professor at the Ingram School of Nursing. It's my pleasure to speak to you today about childhood ethics, looking at ethical challenges relating to nursing care of children, youth, and families. You can see on the slide a bit about me, my background. In addition to being a nurse, I'm also a psychologist, and I'm a clinical ethicist working with children and youth in many different settings, which you can see on the slide here. For those of you who aren't aware of what a clinical ethicist is, I'm an ethics consultant, and so in these different settings, I'm called upon by clinical teams, and sometimes even by families, and sometimes even by youth, to assist with reconciliation of an ethical concern or a challenge that has arisen in that specific setting, to help guide them through doing an ethical analysis and identifying the ethically best course of action along with the teams that I work with. I am also the principal investigator and founder of VOICE, which is a McGill interdisciplinary research program. VOICE stands for Views on Interdisciplinary Child Ethics. Look us up on the web. Our website address is on the slide, as well as our Twitter handle. And follow us, because we're doing a lot of very interesting work, both in terms of research, but also policy development, as well as on-the-ground action with our various partners. So keep an eye out for us. As I said, I'm a clinical ethicist, and therefore I work with specific cases all of the time. And I'm going to start off this presentation, this class, with 4 specific cases that I've worked with. What I will present to you has been anonymized and adapted in order to preserve the confidentiality of those who were involved. But I'm going to present these to give you give you some exemplars of the types of ethical challenges that we could confront in nursing with children, youth, and families. So imagine a situation where you're working with a 7-year-old girl who has end-stage cancer. She's been admitted to the pediatric intensive care unit upon the parents' insistence that everything be done to sustain her life, to prolong her life as long as possible. She's currently receiving mechanical ventilation. She is receiving high-dose inotropic support. Inotropes are medications that support cardiovascular function, cardiac contractility, and so on. And she's having skin breakdown because of poor peripheral perfusion. She has hemodynamic instability because of the extent of her multi-system organ failure. Despite all of this, the parents categorically object to any limitation of treatment, including the limitation of chest compressions. The treating team has met with the family and has proposed what is often referred to as a DNR, do not resuscitate, which is not a correct term for a situation like this. She's receiving many resuscitative therapies already, but what the treating team has presented to the family is, in the event of further cardiovascular collapse, that it would seem wrong to do chest compressions on her. That said, the parents have categorically objected to this idea and want chest compressions and anything done possible to prolong her life. What would be the right ethical way forward in a situation like this? Imagine another situation where you're working in the emergency room and a 15-year-old arrives following an injury from a motor vehicle, and this 15-year-old declares that he's a Jehovah's Witness, and therefore, and he's there with his mother, and both he and his mother say they are Jehovah's Witnesses and object to blood transfusions. The mother says, however, we don't believe in blood transfusions, they're wrong. However, do everything you can to save my child. So they're not saying that let him die, save my child, but blood is a bad thing to take from one person to another, according to their religious beliefs, so they object categorically. Meanwhile, his cardiovascular function is very unstable, his hemoglobin is plummeting, and he's going to require surgery very soon. What should the team do in a situation like this? Now, when we talk about ethical concerns relating to children and youth, we have to be mindful that the children, I'm going to from now on say children or youth interchangeably. Childhood ethics refers to all young people who are minors. And we say minors because being a minor entails some legal vulnerabilities in that they are not independent to act entirely on their own. So young people, children, are vulnerable to specific types of ethical challenges because they have inherent disadvantages, many disadvantages. First of all, they tend to be physically smaller and less powerful, and therefore are prone to a physical vulnerability, whereby they could be physically exploited and controlled and taken advantage of by bigger, more powerful, older people, grown-ups, so-called grown-ups. Children are psychologically disadvantaged in that, for example, they may not have certain types of relational experiences to know how to navigate something like trust. How do I know when I can believe what someone is telling me, when I can cooperate with someone is asking of me? How do I know when it is safe to do so, when it is not safe to do so? With relational experience, we come to understand and navigate how to read those situations. So many children are disadvantaged by not having that experience. Children are inherently socially disadvantaged. For example, they are economically dependent on others for the necessities of living. They can't sustain themselves and therefore are really relying on the benevolence of others, commonly their family, to ensure that their basic needs are being met. And children are legally disadvantaged in that they can't independently pursue that their rights are going to be respected adequately, and that they always require an interlocutor, a legal representative, a surrogate who can act on their behalf as their advocate. And so these are very standard disadvantages that all children face, and some of them to varying degrees depending on their experience and their particular circumstances. And in addition to these fundamental inherent disadvantages, many children are additionally vulnerable because of their particular social context. And so here's an example of the different types of social contexts that many children live within, that these will double or triple or quadruple or further their vulnerability, and that many children will be living in social contexts that could entail membership in more than one of the population groups that you see here on this slide. These are all populational perspectives that we are working with within our voice research team that I told you about at the beginning. So in light of these vulnerabilities that children are predisposed to encounter, we can therefore anticipate that there's going to be particular ethical challenges that are going to be inherent in working with children and youth and families. Some of these were visible in the cases that I started with. And so on this slide, what I'm doing here is listing some of the recurring types of ethical challenges that I've seen as a childhood ethics consultant, as a clinical ethicist. And some of these you would have seen arose in the cases that I started with. So for example, which criteria should be used to determine which therapies would be ethically correct, to decide which therapy should be provided for a particular child? How do we judge that? Who should make those decisions? Who should have the authority to decide what healthcare approach is ethically optimal for a particular child? Where does the voice of the child fit in? Does the voice of the child always matter? Does age relate to that? So-called maturity, capacities, and are some children's voices more ethically merit more ethical grounds for being respected than other children's? How do we figure that out? What about confidentiality? Are children owed respect for privacy and confidentiality? When a child discloses something to you and they say not to tell their parents, are you bound to respecting that? What about situations of pediatric palliative care? How do we relate to, for example, end of life or other types of palliative care kinds of challenges that children children confront, how would good ethical nursing navigate those kinds of situations? And then there are many other types of challenges, and some of those I will be bringing up in the last part of this lecture. To help us navigate those kinds of situations, we're not starting with a total void. There are some important statements that we can draw on. Some are legal and some are ethical that help define what kinds of norms we ought to be drawing on in order to help clarify what would be the ethically superior way forward. This statement here, published in 2004 by the Canadian Pediatric Society, is, in my opinion, one of the most important sources for defining some foundational ethical standards that would apply throughout Canada for all the health professions. Now, some health professions have some more particular statements. We don't have a pan-Canadian nursing ethical statement regarding children in particular. And so for nursing with children, youth, and families, we turn to Canadian Pediatric Society statements like this. And I want to just, I've highlighted 3 specific points from that article in 2004, and I'm highlighting those because they're particularly important. However, this slide is not a substitute for reading the whole article, because there's a lot of nuance, detail, and additional considerations that are brought out in the full article that I don't have enough time here to discuss in detail. So just to highlight the main points, and the underlinings are my own in order to underscore certain types of points. So quoting directly, all infants, children, and adolescents, regardless of physical or mental disability, now that's an important point, regardless of physical or mental disability, have dignity, intrinsic value, and a claim to respect, protection, and medical treatment that serves their best interests. Those last 2 words are key here. The child's best interests, you will see, is foundational. And in essence, all decisions relating to children, in fact, this is not just for healthcare, but also in youth protection, in schooling, family law relating to adoption, custody in the context of parental separation or divorce, all decisions relating to children should be based on that specific child's best interests, adapted and tailored to what we know about that specific child's interests and how they will be affected by one course of action over another. The course of action that will optimize their interests would be considered the ethically superior course of action. So that's foundational. In most cases, moving on, parents are appropriate surrogate decision makers for their children and should give primacy to the best interests of their child. So this gets at who should be making decisions about a child's care. And so it says here that ordinarily parents, and we would often say persons bearing parental authority. So if it's not parents, it could be a youth protection agent. It could be someone else who's been designated by a court to temporarily bear parental authority for a child. So the persons bearing parental authority, let's just say parents, are recognized as the substitute or surrogate decision maker for children. However, this standard also highlights that they should be deciding according to that child's best interests. So a parent may have wishes of their own as to how they would like their child to be treated, but when it comes to acting as the surrogate consenting agent, decision maker, the legal decision maker for their child, they should be choosing what is best for their child according to that child's best interests. And then finally, children and adolescents should be appropriately involved in decisions that affect them. And once they have sufficient decision-making capacity, they should become the principal decision maker for themselves. So this recognizes that, and as you can see here, their being involved, the first part of this point, has no age or capacity condition that applies. So therefore, children and adolescents should always be involved in decisions, and I would add discussions that affect them. This, we would say, in ethics is rooted in a very foundational concept in ethics that's called, that we refer to as respect for persons. Respecting a child as a person entails that we find ways to foster, promote their inclusion, their participation in discussions and decisions that affect them. However, legal and ethical standards usually establish a threshold at which point, beyond that point, they can actually be decision makers for themselves. And basically, as it says here, once they have decision-making capacity, that's a key term here, decision-making capacity, which generally means the ability to understand, the ability to bear responsibility, mindful of the consequences and benefits tied to one option or another. If the child has that decision-making capacity, then they could become the principal decision maker for themselves. This does not mean that for children who do not yet have that decision-making capacity, younger children, that they have to be necessarily excluded from all discussions and decisions that affect them. It just means that they cannot bear the legal responsibility and the weight of that responsibility independently for decisions that affect them. In those cases, the parents would be the legal decision makers. Now, what you saw before was that the best interest is a foundational concept here. So when we ask the question, which criteria should determine which therapies ought to be provided, how do we know what's the right treatment for a child or what's the best treatment for a child? Well, best interest standard implies that we should choose the treatment option that will optimize that child's best interests. What does best interest mean? That's a bit of a problem. There isn't one universal, clear, standard, objective definition of what best interest is, but in general, it's widely agreed that best interest implies the course of option where the benefits are proportionally greatest in relation to the burdens of that course of action. So this is based on proportionality. The course of action, so let's say you're talking about, do we do chest compressions on this child or not? What would be the benefits and what would be the burdens of doing the chest compressions? What would be the benefits and what would be the burdens of not doing chest compressions? And then the option where the benefits are proportionally greatest in relation to burdens would be considered the option that's in that child's best interest. Now, I've highlighted at the bottom of the slide, but which benefits and burdens are most important? Is prolonging life more important than what the quality of that life would be like? And here's the problem. We don't have a universal consensus on that. We know that many families, for example, have very different views on the relative value of quantity of life in relation to quality of life. Some families, whether it's cultural, religious, or just personal convictions, might believe that prolonging life, even for another day, is always worth it, regardless of how intrusive some of the treatments might be. Whereas for some families, quality of life is important, and it's not worth doing very intrusive things if the outcome is, if the quality of life during the treatment is going to be severely difficult, and if the long-term outcome is going to be compromised in relation to what the parents' aspirations are and what the parents' conception of what's best for the child would be. This gets into some very sensitive topics relating to how do different forms of disability and other types of outcomes matter in terms of a child's best interest. And in recent years, there's been some very interesting work in this area, and I will say a bit more about that in a later section of this class. So, having highlighted that best interest is the foundational criteria that we use to decide what's the best course of treatment, then the next important question is, well, who gets to decide what's in a child's best interest? Who's authorized to decide what's a child's best interest? Well, there's different ways to answer that question. In many ways, anyone who has a duty of care towards a child, anyone who has a responsibility toward that child, and that means every healthcare professional that is working with that child, as well as parents, school teachers, and others who have an engagement with that child. Now, school teachers are not normally going to be involved in healthcare decisions, so we'll leave them out for now, for this kind of decision. They all have to judge how will their own actions affect that child's best interests, and have to act in light of what's going to be optimizing that child's best interests. So everyone decides what's in the child's best interest, because everyone is continually having to discern and to decide, how will I handle this specific situation here? Now, often when you see a question like this, most commonly it's referring to a meta decision, a big decision on, do we resuscitate or not? Do we do the surgery? Do we initiate cancer treatment or not? Or do we shift from full cancer treatment to adapted cancer treatment, and putting a greater emphasis on what commonly is referred to as palliative care, comfort, and so on, optimizing comfort. So those kinds of decisions, which often relate to the medical plan of care, the plan of care that entails prescriptions that are documented by physicians, even there, of course, physicians have a key responsibility in defining how different types and different courses of treatment will affect the child's best interests. But even there, although physicians have a key role to play in specifying which medical treatment would optimize the child's best interests, legally, the person with the ultimate authority on that child's what course of treatment would optimize the child's best interests is, in the context of Canadian jurisdictions, would be the parents. Parents is the agent who is authorized to decide on behalf of the child. Now, you're going to see later, there are contexts under which some children can also decide for themselves. So when it comes to consenting to treatment, the authority commonly would be the parent. Under certain circumstances, it could be the child. And all of the others who are involved with the duty of care to the child, so physicians, nurses, respiratory therapists, psychologists, pastoral care, social workers, all of the others also have to make decisions about what's in the child's best interest as they make decisions about their own actions. But ultimately, in terms of deciding on what are going to be the goals here and what's going to be the master plan here in terms of the care plan for this child, the parents, persons with parental authority, are the decision maker for those. Where the child fits in, you're going to be hearing about more as we move forward. And so just to introduce that point, I want to say a little bit about how does the voice of the child fit into all of this. I'm going to devote some significant attention to it very shortly, but let me just introduce it here by saying that the voice of the child matters in a couple of different ways. There's a certain standard at which the child is recognized as being capable, or in fact required, to consent to treatment, either independently or sometimes with parental corroboration. And that's specified by law in every jurisdiction. But even when the child or youth is not at that age or at that threshold of capacity to decide for themselves, within childhood ethics, many of us have been promoting this notion of recognizing the child's capacity to assent to care. So if a younger child is not legally authorized to provide consent and to decide for themselves, that's a legal standard. What we've been promoting within childhood ethics is a way of recognizing the child as a person, the younger child who doesn't have the legal right to consent, is that we recognize that they should still have a voice and a say in how they will be treated, and that to the extent to which it is possible, that we elicit their voluntary cooperation. Assent is not the same as consent, because ultimately you may still do certain things to a child without their assent. You've tried the best you can to elicit their voluntary cooperation. But an ethical analysis has been able to make a compelling case that we can still go forward with this intervention, regardless of the child's dissent, absence of assent. Well, it's not exactly the absence of assent, it's a clear expression of rejection. But there, you would have done the best you can to really be mindful of that child's preferences. At this point, we will now shift to a different section. Even for young people who are not legally authorized to provide consent on their own, this does not mean that they should be excluded from all discussions and all decisions regarding their care. And so within childhood ethics, many of us, myself included, have been promoting this notion of assent, so that although they may not, say for example, a 10-year-old may not have the legal decision-making capacity to make a decision on their own about, say, cancer treatment, antibiotic treatment, surgery, and so on, is that in order to still respect their personhood, respect them as persons, and respect that they have an interest in being heard, and that be treated seriously in the way in which we decide what's their best interests, is that we do the best we can to elicit their assent. And I'm defining assent here as optimizing the child's understanding of their condition and proposed interventions and investigations, and then seeking that child's voluntary cooperation to the greatest extent possible. There are going to be situations where the child's capacity to participate in consent is going to be complicated by the fact that some children communicate differently. So what some people refer to as communication impairments. We prefer, within the work we do, and many people working with disabled children and youth prefer not to use the words impairment, because that's characterizing their particularities as a kind of a deficiency. Different people have different types of functionalities, and so some young people communicate differently, and that's the term that we prefer. And so what in those situations is required is to look at how to draw on communication strategies, devices, alternative and augmentative communication aids, to look at how to optimize the child's understanding of the dialogue about their condition and the treatment options, and how to optimize their expression of what their particular preferences are and how we move forward. And so in this paper, we have tried to demonstrate in more depth, drawing on our respective work, giving many examples of showing how to elicit the voice of young people who communicate differently. And in many situations, this would imply the participation of the parents as a communication interlocutor, as an interpreter, as a communication mediator, particularly children who communicate differently, where we don't really, it's hard for us to understand what they're saying. Parents will have learned how different expressions can be consistently interpreted in a particular way. And so parents can be very, very important in helping us with really being attentive to that child's own particular voice and experiences. And in this early section on foundational concepts and norms and respect for the personhood of the child, I want to just close on this last concept, and that is confidentiality. Respect for young people's privacy and confidentiality. There's very little written about this. We tend to think about confidentiality as something that matters more to older people, and many people take great liberties in telling stories about children that may be comical or fascinating and interesting, and there isn't as much pause, in my experience, exercise that this is a person, and that even if the way in which we talk about them and disclose information about them can entail an indignity, and it's a disrespectful use of information that we have access through the privilege of our professional relationship with them. The Canadian Pediatric Society statement from 2004 states that all information presented to patients, so that means children and youth, families, or the child and adolescent's legal guardians should be truthful, clear, and presented with sensitivity. So we've already established that there needs to be a transparent, honest, and open reciprocal disclosure with young people. On occasion, what will happen when we are going to ensure that our communication is open, honest, respectful, authentic in this way, is that some children are going to express private things. And this is a paper that we published within our voice teams to specifically address how to navigate privacy and confidentiality with young people. This was published in the Canadian Pediatric Society Journal. And so, we discussed a couple of cases relating to sexuality and sexual health. But within the paper, we really work out how to navigate what's the ethical significance, the ethical stakes, as we have to determine how to respect the privacy and confidentiality of young people. This is particularly challenging in a young person who is not considered legally independent to make decisions for themselves. So within Quebec, for example, starting at the age of 14, young people can consent independently, and therefore anything they disclose to you, short of disclosing something that could entail a serious risk of harm to that young person or someone else, where there are clear standards that apply for all patients, including adults. But short of that, then they are entitled to full respect of privacy. But what about a younger minor, a 12-year-old, who tells you a secret that you think has important implications for treatment? A 12-year-old with end-stage cancer who tells you they don't want to continue with this treatment, they don't like it. They've understood, they've heard that the death is imminent, that they could die shortly, but then they don't want you to share this with their parents because they fear that their parents will be disappointed in them for not wanting to continue fighting this cancer, because that's the usual tone of the preferences expressed by parents. What should a clinician do in a situation like this? And so we explore those challenges in great depth in this specific article here. I will not review additional considerations relating to confidentiality, but I've given you 2 slides here for your information. These are not specific to children, so situations under which there are exceptions to respecting confidentiality. And this is for young people as well as people at the age of majority, adults. And there are standards for how we breach confidentiality. There are very clear legal and ethical standards that give us very, very narrow permission to an obligation to disclose some private information, and in particular when there is an imminent and serious risk of harm. So that closes the first 2 parts of this presentation, really reviewing the foundational concepts relating to childhood ethics, nursing care with children, youth, and families. So with this, we now shift to a new topic. So in this final section, we discuss specific ethical challenges inherent in different types of clinical settings. And so I'm going to go review how the particular challenges that will arise in these kinds of settings and some of the current thinking on what would be ethically optimal ways forward. So in the context of working with newborns, what particular challenges arise and what is current thinking about optimal ethical approaches? So in the context of working with children, and again, I don't want to create a caricature here of this very complex field, but there are 2 types of ethical challenges that arise quite commonly and they're on very different poles of a continuum. And so the first, and probably the most common, is situations where clinicians or sometimes families feel that the treatment that we're providing to a newborn is excessively burdensome. So this could be a newborn who is either born very prematurely or is born with significant complications surrounding the period of labor and delivery, or is born with some congenital problems, and so has significant health problems. And so there are questions that will be raised either by some of the members of the healthcare team, or one or both parents, where there's a questioning of, are we doing the right thing by doing all of this? If the child's long-term prognosis is severely guarded, for example, if we're projecting severe disability, is it right to do all that we are doing? And so there are some very helpful standards that have been published that define, for example, with prematurity, at what level of gestation and with which presenting signs and conditions would resuscitation be considered required, optional, or unwarranted. And so there are some helpful standards, and I've presented one on this slide that can really help guide how to navigate those kinds of situations. Interestingly, there's another issue that arises, and some clinicians and some families have raised this. In fact, a number of families that I work with have raised this, where there's a feeling that newborns are not being treated like older children, that in fact, that we, in many situations, are prepared to let die, a child whose long-term prognosis might involve certain forms of disability, but if it was an older child, we would have treated that child more vigilantly and have done more to save that child's life. There's a sense of newborns being in a bit of a betwixt and between state of personhood, in that there's this view that whereas for some newborns, if a long-term health problem would have been identified prenatally, it would have been considered legally acceptable to terminate that pregnancy. But then a child is born with disabilities that are quite comparable, or genetic, or brain injury resulting from labor and delivery complications, then sometimes will be parents or some healthcare professionals are saying, well, we should limit therapy and let this child die. And so some ethicists within neonatology have highlighted that, are we perhaps abdicating our moral responsibilities towards these children and these newborns, and not treating them as full persons who also should have their own individual best interests assessed and weighted in the way in which we would for an older child. And so the article that I've cited here, Are Newborns Morally Different from Older Children, helps to highlight those concerns. I've made several references throughout this class on long-term disability and what bearing does that have in how we decide, how we understand a child's best interests. Our voice team has made some important contributions to this literature, not just us, many other people are doing valuable work in this area. And this is probably one of our most cited works that we published in 2006. And this was research that we did with families whose children were living at home with respiratory assistive devices, so assisted ventilation. And what we were able to demonstrate was that until that point, our own experience and a lot of literature had yet to demonstrate that, in fact, these children have significant capacities to live meaningful lives within their families and within their homes if some reasonable accommodations and adaptations were made in their everyday lives to assist their breathing and to allow for them to have access to schooling and other activities within community life. For example, with some of the children that we interviewed in that study, we heard from them directly that they demonstrated quite clearly that for them life was worth living, despite the fact that they might have had a tracheostomy or had ventilatory devices and significant physical disabilities. As one 9-year-old said, I think I will need it for a long time, a very long time, referring to tracheostomy and ventilator. It helps me to breathe, so I don't care. It's okay with me to have it. It's better to have it than being dead. So it's very important to look at and confront our own prejudgments, prejudices towards life with disability. There's a tendency to think of that life with disability as a life of deficiency and a life not worth living. And a lot of that is outright prejudice. We really need to understand what is this life like for the person who's living it, and how much might the hardships be hardships that are resulting from abdication and abdication from responsibility of those around those people living with disabilities, to really look at how to facilitate their lives, how to provide some assistive devices so that the environment can be less disabling. Because ultimately, in this disability studies work has shown that ultimately it's the interplay between person's body functionality and the environment that really defines an individual person's disability. Environments can enable or can disable based on the forms of assistance and facilitators that promote inclusion that are available, or the barriers and obstacles that exclude and prevent them from participating in activities in their worlds. A 4.5-year-old girl, referring to her BiPAP device, positive airway pressure device, that supported her breathing, she gave it a nickname and called it her PAP. My PAP makes me happy. I really like my PAP. My PAP is good because it helps me to breathe. So yet another example. From the outside, one might have thought, oh, what a worrisome reality that this little girl has a tracheostomy. Well, in this case, she didn't, but has this device that is supporting her breathing, and think of her as deficient, whereas she just sees it as assistive. And some of these children would describe their assistive devices in the way in which other people refer to glasses or dentures as devices that optimize their lives and promote their ability to participate in activities in the world around them. What about the context of critical illness? What kinds of ethical challenges arise there? The pediatric intensive care unit, for example. Well, there are, with critical illness, quite commonly the work we've been doing has shown that the ethical challenges relate to empirical uncertainty. It's quite commonplace with a child with a critical illness where their diagnosis is unclear, particularly during the period of grave instability. And we're often working with speculations on what is probably going on here. And therefore, also, their prognosis is going to be unclear. Their prognosis becomes more clear over time. And it becomes more clear if we sustain their lives and if we do resuscitative therapy to sort of see how that goes and have a better idea of what their long-term outcome is going to be. So it makes it very hard to make decisions now about what's the right thing to do, because sometimes the outcomes can be very disappointing. For example, in terms of it being disappointing for parents, where parents had a hope for return to life the way it was before the critical illness, but then the longer-term survival of the critical illness could be one with severe disabilities, for example. And parents might say, well, we would not have done all of this if we knew this would be the outcome. And this is quite inherent in pediatric intensive care, that we having to work with all of these uncertainties and make best judgments possible in light of those. And often and within intensive care, for clinicians and with parents, there's just a sense of having to make choices among bad options, what feels like tragic choices. To have to choose between continuing with resuscitative therapies, where the likely outcome could be severe disability, or to withhold or withdraw resuscitative therapies, where the outcome will be certain death, those just don't feel like ethical choices. They just seem like awful choices, and it's a very uncomfortable and morally distressing experience to have to be an active decision maker in choosing an option among only bad options. As with many segments of our populations, many children are living in social, economic, cultural, political contexts that entail significant inequities. And so these are some of the children that we know are facing significant inequities. And so children with disability, and I made some reference to it before, there are many children who live hungry every day. Migrant newcomer children have a number of barriers and obstacles to full participation and community life and full recognition and respect of their rights. Indigenous children, as we know that throughout history, have had a lot of their personhood and rights breached through residential schooling, and more recently through some of the standards within community life that have been perpetually compromised through across the board policy making, for example. And then within many segments of the world where there are socio-political contexts that can systematically really amplify the types of disadvantages that children live with, the disadvantages I started with, that I outlined at the beginning of this class, that can be very seriously amplified depending on different regions of the world and the local social context. And I want to take this moment to also add that at this very time, as we are in the throes of the coronavirus pandemic, the work that we're doing within our voice team and others as well in different parts of the world have highlighted that a pandemic like this and the emergency measures that are taken to ensure distancing, various forms of confinement and distancing measures that are being put in place, in many situations, many children's vulnerabilities are being amplified. So whereas for children who are living within socially advantaged contexts, homeschooling is an inconvenience, it's burdensome, can be somewhat disruptive and unpleasant, and sometimes boring, and it can rupture friendships and so on. And so they're having to rely on maintaining friendships through social media or distance communication. And parents' work might be disrupted, and they have to become home teachers as well. For children whose parents may be linguistically, culturally, and schooling diverse from the mainstream society, children who are living in the context of poverty and therefore with limited technologies in the home, limited capacities to perhaps hire additional tutorial support, and parents living with parents who have precarious working conditions, whose work hours make it very hard for them to ensure schooling at home, or precarious working conditions where those parents may be in fact at risk for exposure to COVID-19. In all of those situations, the usual disadvantages and vulnerabilities that are inherent in childhood are tremendously amplified, and we need to be mindful that some of these families are bearing a burden of distress that is really extraordinary, and particular measures are required by those of us who work with children and families to look at how their particular needs need to be recognized, and that services need to be adapted in order to respond to those. All of that said, I recently participated in an expert panel that was convened by the Canadian government, Minister of Health and Minister of Justice. In 14 various childhood experts were brought together, and I was one of those, had the honor of being one of those, where we were asked to examine the current state of knowledge on medical assistance in dying, and the merits and limits, challenges involved with also including mature minors. And so this report, and I've given you the link here, really reviews the conditions under which and some of the challenges that would be required if the law was to be adopted in order to include mature minors as well. That day might come, that day might not come. I would refer you to this, if you have a special interest in this topic, I refer you to this report because we provided a very thorough analysis of those issues. So working towards a conclusion, and the last few minutes, I just want to tell you that, again, about this team that I lead, VOICE, Views on Interdisciplinary Childhood Ethics. Go to our website. We have lots and lots, and you'll see the website on my final slide. We have published quite a bit on the various topics I've discussed here, so you can get a lot more information about some of those topics. And within our work, we've really tried to highlight what are the ethical challenges that are being confronted by children and youth in different kinds of situations, and what would be the ethically optimal ways forward in working with children and youth. And so I just want to highlight some of the main points that have either been implicit or explicit in this class. And one of those is that we really need to optimize the ways in which we listen to, attend to, recognize, and respect children's voices. This is rooted in a notion of recognizing a young person's as a person, and a term that you will find in the childhood literature is the notion of the child as an agent. Young people are moral agents. They have their own way of understanding right and wrong, good or bad, just and unjust, and things are morally meaningful for them. Even if they reason in a way that's different from you, it is no less meaningful for them. And in order to recognize their agency, we need to look at how to optimize, how to maximize their inclusion and their participation, the sharing of their experiences, and the sharing of their concerns about how the way we do things would affect them, so that we can arrive at the most informed determination of that specific child's best interests. And so I call that evidence-informed best interests. And in particular, that we're drawing on clinical evidence that has been disclosed by that child, seeing how that child's views, preferences, and experiences have been affected favorably and unfavorably by the things we've done to date, and making sure that we use that to arrive at the most individualized assessment of how the various courses of treatment will affect this child's best interests. We should also turn to the research evidence that has shown us how children's best interests could be impacted. So, for example, until we had the more recent literature on life with disability, we had presumed that it was contrary to a child's best interest to survive with disability. Very hard to ask a child, do you want to be disabled or not? Ask parents, do you want this child to survive with disability or not? When we had been relying on very faulty and prejudicial presumptions about life with disability. So now we can look at what is the research evidence shown us about what life can be like, so that as we try to assess this specific child's best interests in making a decision about tube feedings, ventilation, treatment, cancer treatment, and so on, is that we look at what is the research evidence, what have we learned from research evidence about the range of possibilities of what this life could be like. We also need to be mindful of children's rights. What children's rights relate to the situation at hand? And so we need to do a better job of being aware of those rights. And in some of our publications, we highlight what some of those are. And those include the child has a right to be protected, having their best interests protected. Children have a right to be heard and to participate meaningfully in decisions that affect them. Those are examples of rights that are transversal, that are rooted in the United Nations Convention on the Rights of the Child. And so we need to make sure that the way in which we determine a child's best interests is not incongruent or in conflict with what has been deemed to be their rights. We need to act in a way that really optimizes the recognition of children's voices and their agencies as a form of showing respect to them as persons. And we need to work to advocate with young people, not for, because, and we often talk about advocating for certain vulnerable people. And many people who have had the experience of having others advocate for them can inadvertently create a feeling of being pitiful, and can really be experienced as humiliating and denigrating. We need to look at how do we establish relationships with young people where we identify what are their concerns, what are their equity and justice concerns that they are living in their lives, and in what ways can we work with them to help advocate for more ethically proper, more ethically correct policies and practices. In full recognition and respect of young people as agents, as decision-making agents, as persons with participation rights, drawing on the United Nations Convention's Article 12, there is a small movement, and it's still incredibly small and nowhere where it should be, small move towards recognizing that young people should be at the table, not literally, because that's often a table of adults and unwelcoming, but through social media, through discussions and other ways that young people should be included in the way in which we design services, the way in which we develop policies within hospitals, at ministerial levels. They need to be active participants in how we make decisions. In the Canadian government panel, where we produced a report on looking at the inclusion of mature minors for medical assistance in dying, given the work we're doing within Voice, I had the opportunity to interview some young people and video record those interviews so that we would have young people's voices to be considered in how the Canadian government moves forward in developing policies on medical assistance in dying relating to mature minors. And there's a synthesis of that in the report that I told you about a moment ago. And I think those kinds of examples need to be commonplace rather than the exception. In terms of everyday practice, we really need to look at promoting strategies that will help reconcile ethical concerns that arise in nursing care with children, youth, and families. We need to promote ethics discussions within nursing teams so that when nurses review the plan of care for that day, for the week, particular cases, that within the nursing team, there's a focus on identifying what are the key ethical concerns we have here and what should we be doing about them, but also to ensure that nursing is optimally engaged and active participants in interprofessional team discussions. Through history and through my own experience, there's often a tendency for nurses who participate in interprofessional teams on ethics discussions to play more of an observer role, and there's often a tendency to not contribute their own particular observations on what a child's everyday life is like and how one course of treatment over another seems to affect that child favorably or unfavorably, and that a nurse has a lot to say in helping to define what's in a child's best interest. And in particular, we need to recognize that if a nurse is going to play a significant role in carrying out a plan of care and maybe, in fact, performing some of the interventions that are being decided upon, that a nurse doesn't feel like they're a perpetrator of unjust wrong, that they don't feel like they are doing investigations and interventions on a child that they think are ethically wrong. That's a breach of their moral duty toward that child, and they need to speak up in team discussions to ensure that their perspective is fully integrated into the best plan forward. And then we need to look at how do we ensure that every team, nursing team, interprofessional team, has access to ethics consultations. And depending on the institution, you might have an individual ethics consultant like myself, who's practicing in several areas, a consultant that you can call upon either to meet with your nursing team or with an interprofessional team, to look at how to analyze a specific situation. And in some situations, in some settings, you may not have an ethics consultant, and you may have a clinical ethics committee. And in some contexts, you have both. And in settings I work in, we do have both. So there's me as an ethics consultant, and there's also an clinical ethics committee. And in some situations, in particular, maybe some of the more complex situations, a full ethics committee consultation might be called upon to bring additional perspectives. And often as an ethics consultant, I will highlight the importance of having the full ethics committee be involved in an ethics consultation. When we are actually doing an ethical analysis, there is a lot of literature on different kinds of approaches and models that we can use in order to analyze a specific situation, to identify what's an optimal way forward. I've published one. It's not the best. I'm not saying it's the best, but it's congruent with the approaches I've been describing here. And so therefore I'm recommending it, and I believe it really is nicely attuned and aligned with the vision of childhood ethics that we've been promoting within our voice work. And so the reference is here on the slide, and we refer to it as a rapprochement model. There are not very many bioethical models that are specifically focused on childhood. This one is not specific to children, but in this article, you'll see all the examples that I discuss. Almost all of the examples in this article relate to children, because that's where my experience is. And with that, I will end this very, very lengthy lecture with multiple sections, reviewing sort of foundations. I started with foundations in childhood ethics, and then looked at operationally notions like consent and confidentiality, how we operationalize those legally and in practice. And then I did a review of different types of clinical settings where nurses are working with children, youth, and families, and some of the ethical challenges that they could face. And on this slide, you have information about our voice team, our website, our Twitter handle, and you also have my email address. If you have a particular concern that you would like to discuss, I advise you to discuss with your own professors first. And then if you have any residual concerns that you want to take up with me, and in particular want to discuss further some of the points in this lecture, I welcome hearing from you. And so I wish you the very best in your very ethical practice with children, youth, and families. Thank you so much.
Estamos de volta agora, ao vivo, com o professor Franco Carnevale. We're back and alive. Thank you, Professor Franco, for your exposition, your explanation. And the public was very exciting with your presentation, and many questions came to the chat, and you have an opportunity to read it and answer. And now I will pass exactly to the public to answer this question. Okay, Franco, that's fine for you?
Yes.
Okay, so at first, I need, Franco, to clarify some issues that in the translation, maybe it wasn't clear, okay? Because we have the Portuguese subtitle, and one specific part, I think that was a misconception with the translator. In the part that is talking about the difference of assent and consent, and then I will explain to the public in Portuguese, okay? Because when they translate, they put all as consent, and you were very clear when we were talking about the difference between two, ok? Primeiro, eu expliquei para o Franco que tem algumas questões que apareceram como subtítulo na tradução que precisam ser diferenciadas, porque a pessoa, né, que fez a tradução não é uma pessoa da área de pesquisa, né, clínica, das pesquisas com criança, então é importante a gente esclarecer ao público. Ele deixou bem claro na apresentação que existe uma diferença significativa entre assentimento e consentimento, e na nossa legislação, que é a resolução 466, a resolução 580, né, resolução que trata da eticidade da pesquisa com criança, A diferença entre assentimento e consentimento está exatamente em respeitar a cooperação voluntária da criança participar de um determinado procedimento, seja ele um procedimento clínico ou um procedimento de pesquisa. Então, é uma concordância da criança, uma concordância voluntária em participar. Já o consentimento é uma autorização legal, né, do responsável pela criança para que ele participe. Ambos são fundamentais quando se trata do reconhecimento da dignidade, né, e o respeito à privacidade e à confidencialidade da criança. Então, esse comentário eu gostaria de registrar para o público, né, que não são termos intercambiáveis, eles não são sinônimos, tá? Também deixar para o público um conceito fundamental que ele explorou no final da apresentação dele, é o fato de trabalhar com a criança, work with, and not work for, ou seja, trabalhar com a criança e não para a criança, envolvendo-a nesse processo de cuidar e no processo de pesquisar, independente, regardless, como ele disse, da condição da criança. Então, feitos esses esclarecimentos, vamos às perguntas do público, né? At first, Franco, there are a lot of thanks and congratulations for your presentation, and that was really clear, no? And the public was very attentive to your exposition, ok? A primeira pergunta que foi feita, e eu vou fazer a leitura para que o público conheça a resposta do Franco, foi feita pelo Rafael Lima. Ele pergunta se existem abordagens padronizadas para situações em que há suspeita de violência, e, claro, ele fez a pergunta pensando no Canadá. Mas também há algumas inovações importantes que estão sendo... desculpe, gente, eu vou fazer a pergunta exatamente como ele fez, tá? E aí eu vou deixar que o Franco responda, tá bom, Franco? That's okay, Franco? The first question was Rafael, and I'll read it in Portuguese, and then you can answer and I will translate, okay?
Ok.
Ok. A pergunta foi, quais são os procedimentos em seu país para atender uma criança com sinais indicativos de algum tipo de violência? Franco, por favor. Please, Franco. You can read your answer in the chat, and then I'll translate, okay?
Okay, I'll go find my answer then, or I could just answer it again. So in the context where violence is suspected, there's the usual approach that is sometimes mandatory, and that is when there is a concern of a serious harm for a child, there is an obligation to notify the youth protection officer, and they will do an evaluation and an intervention. However, this is frequently very traumatic for the child because the child and the family lose total control over what will happen. And in some situations where the risks are very high, many feel there is no other choice because a major intervention is required. However, there is movement to finding less traumatic ways of dealing with these situations where we're trying to do some mediation that is more inclusive of the child's experience. And so when I have done consultations in such situations, I construct an exchange between the professionals, the parents, and the child to help the child explain what is important for them, what do they need, so that when solutions are going to be made, they will use a definition of that child's best interests that is informed by that own child's experiences.
Obrigada, muito obrigada, Franco. Eu vou fazer uma síntese, porque na resposta que ele deu, ele acrescentou mais elementos. E alguns desses elementos são muito parecidos com os procedimentos que nós adotamos no Brasil. Então, há situações em que é obrigatória essa notificação, então há a notificação compulsória, e uma autoridade é designada para acompanhar esse caso. mas ele, como consultor clínico, né, ele tem tentado encontrar uma solução mediadora, porque essas abordagens padronizadas para situações em que há suspeita de violência, elas já estão determinadas, né? E nessa abordagem padrão, a criança pode sofrer, ele pode ser vítima de maus tratos, inclusive com a própria abordagem padrão. Isso pode sinalizar anonimamente ao sistema de proteção das crianças e jovens, e eles vão investigar e vão intervir sobre ela. Muitas vezes, essas intenções no processo de investigação, como ele disse, elas são muito traumáticas para a criança. Como, por exemplo, né, essa criança pode até ser retirada do seio da sua família. E eles têm desenvolvido, ele como consultor clínico, algumas abordagens mais mediadoras, né, para incorporar a voz e a experiência da criança no encontro, né, com famílias profissionais, os familiares envolvidos, né, os familiares da proteção à criança, os profissionais, e sempre pensando que o elemento-chave é o melhor interesse da criança, e assim encontrar a melhor solução para a criança. Thank you, Franco.
And Ivone, can I add a comment that I would like to make to the presentation itself? There's another piece I would like to contribute.
Okay.
And I want to highlight that the work that we did in childhood ethics, we have now expanded it to develop a children's nursing model. That the approach that I described should not be used only for ethical problems, but it should be used for all dimensions of nursing practice with children. For example, the way you evaluate symptoms, pain, and other kinds of symptoms. It requires this kind of an approach where you can really ensure that you're putting a lot of importance to the child's expressions. The way in which you develop the best plan of care for this child. It should be using these kinds of approaches when you have a dialogue with the child to really understand the impacts for the child, the good and the bad, so that we can come up with a plan that is most respectful of the child as an agent. We've been using this in our curriculum for about 4 or 5 years now in how we teach children's nursing.
Okay, let me translate this part and then you can continue. Ele disse o seguinte, que esse modelo, né, de Childhood Ethics não é usado somente na avaliação ética, mas também como modelo de enfermagem da infância, né, o modelo Childhood Ethics. Ele pode ser usado para outras dimensões do processo de cuidar de enfermagem, como, por exemplo, avaliar sintomas, porque requer a incorporação da expressão da criança, de expressão de emoções, da voz da criança, do que ela considera como importante para ela. No planejamento do cuidado, é preciso também escutar a criança e envolvê-la nesse processo do planejamento desses cuidados. E também eles têm aplicado esse modelo, né, de cuidado ético, vou chamar assim, né, que é o Childhood Ethics, modelo de cuidado ético na infância, tem sido incorporado no currículo para a formação de enfermagem. Go ahead, Franco, if you have more to add.
No, that's okay. We haven't published about this yet. I have one article, but it is being evaluated right now. So.
Ok, tem um artigo que ele vai publicar sobre isso, que está em processo de avaliação nesse momento. Então, muito obrigada, Rafael, pela sua pergunta. Se por acaso você não se sentir contemplado na resposta, por uma falha aqui nossa, né, não na falha da resposta do Franco, é só você nos adicionar aqui no chat, tá bem? A outra pergunta foi feita pela Maria Carolina, né? Maria Carolina perguntou ao Franco, qual é a abordagem aos cuidados paliativos em recém-nascidos que são abandonados em maternidade? A decisão caberá à equipe médica? Então, Franco, the question of Maria Carolina was, what's the approach of palliative care for newborns that are abandoned in maternities? Is the decision a responsibility of the medical team? What did you answer?
So in Canada, if parents are not able to exercise their authority and responsibility as the legal decision makers for the child, then it's the director of youth protection that will nominate someone, a professional in youth protection that will be the substitute decision maker and will provide consent for that child.
Thank you, Franco. Lá no Canadá, né, se os pais não puderem exercer a autoridade e a responsabilidade como um tomador de decisão legal pelo seu filho, a autoridade de proteção do jovem, né, então, o diretor, né, que é responsável pela proteção dos jovens, ele vai designar alguém para exercer esse papel, que assumirá esse papel de tomador de decisão. Ele será o substituto que dará o consentimento para esse bebê. Ok? Mariane Caetano foi a outra pergunta feita, né? Da Mariane Caetano. No caso de crianças, né, menores de idade em paliativos, por exemplo, que já têm um certo entendimento da sua condição, como é levada em consideração suas decisões, mesmo sendo contrária à de seus familiares? Nesse caso, prevalece a vontade de quem? A vontade da criança ou dos pais, né? Então,
so there's two ways to answer that question. There's
okay,
the legal answer is that legally what the parents decide is usually the decision that will dominate, unless the health professionals are concerned that the parents' decisions are harmful for a child. Then they have to go to a court and ask a judge to consider the child's views. This is very rare to go against the parents' views to court unless there's a clear sign of harm. That's the legal solution. You want to translate that, and then I'll talk about the ethical solution.
Yeah. A primeira, né, é uma resposta que ele traz, né, mais legal, com base na legislação canadense. Quer dizer, legalmente, os pais decidem, a decisão dos pais é o que vai dominar, a menos que os profissionais de saúde se preocupem com as decisões desses pais. Então, eles podem ir recorrer, né, à Suprema Corte, ao tribunal, e pedir a um juiz que considere mais fortemente, né, o desejo da criança. Mas isso é muito raro acontecer do ponto de vista de um processo legal. Então, agora ele vai responder a segunda parte. Then you can move forward to the second answer.
So the second answer is to look at the ethical dimension. If we recognize that children are moral agents who have morally meaningful aspirations and concerns, then their views should be given ethical weight. In fact, Article 12 of the United Nations Convention on the Rights of the Child recognizes that children should participate in decisions that affect them, and their views should be given ethical weight. So I think we have a responsibility to work with the child and the parents to find a solution that is acceptable for all of them, but also paying special attention to the extraordinary powerlessness of the child.
Ok. A outra resposta, né, a segunda resposta, é uma resposta ética, né? Se reconhecemos que as crianças elas são agentes morais, né, que elas têm aspirações, desejos e preocupações moralmente significativas, então os pontos de vista delas devem receber um peso ético importante. Isso é reconhecido pelo artigo 12 da Convenção das Nações Unidas sobre os Direitos da Criança. Ele pensa que nós devemos ter a responsabilidade de trabalhar com a criança e os pais para sempre encontrar uma solução que seja mais aceitável para todos, prestando sempre atenção, muito especial, à extraordinária, né, impotência que a criança tem nesse processo decisório. Em tais situações, é importante olhar sempre que tem o peso da autoridade dos pais na hora de tomar a decisão. Bom, do próximo é um comentário de Larissa, que diz que não tem nenhuma pergunta, mas ela agradece pela oportunidade de ouvi-lo. Ela está bem reflexiva diante de tantas informações. Ela diz, I have no question. I thank you for the opportunity to listen to you. I am reflecting upon so much information you share with us. Eu tenho, Franco, I have a question that I have two questions for me, okay? from me to you, and then I'll move again to the private chat and see if there are more questions, okay? My first question for you is, what kind of criticism have you heard as an advocate for children and youth decision-making? Sometimes I read, some criticism, ou seja, algumas vezes eu leio algumas críticas àqueles estudos que defendem a participação da criança na tomada de decisão, como se elas fossem uma tábula rasa, como se elas não tivessem condições de tomar decisão. Sometimes I heard some people just saying that children are not able to make decision or to take participation, especially disabled and children with special needs. What do you think about it?
That is the most common reaction I get. The reactions I get are more negative than positive all of the time. I think everybody seems to think in a binary way.
Mm-hmm.
A person is either capable or incapable. And they don't think that they don't recognize the way we work with these children can improve their capability to participate. And also, just because we're talking about respecting and recognizing their voice, it's not the same as with an adult, where we recognize them as independent and free to make whatever decisions they want. Children are still children, and they still have a right to protection. And sometimes we may not do what they want, because what they want might be very, very harmful.
Mm-hmm.
What I ask is that when we act against their wishes, we see that as an ethical problem. But we might still do what we think is right after careful consideration, trying to get their assent as much as possible.
Mm-hmm.
So in summary, I think the biggest criticisms come from people who are fixed in this idea of immaturity and incapacity, which I think maintains a very disrespectful and humiliating approach to children.
Yeah, you are positive. I've heard many times, especially when I'm discussing of ethical participation. I say ethical participation, not research participation as a volunteer, but ethical participation in the study. As a member of the ethical committee, they also say that children are incapable to make decision, or they will not understand what the researcher want to share with them, and then they not consider the importance aspect that you said, respect the wish, in the meaning of respecting and recognizing their voice. I also have heard about it. I will explain the public. Eu perguntei a Franco qual é a crítica que ele tem sofrido, né, em relação à defesa da criança e do jovem na tomada de decisão, especialmente crianças e adolescentes na tomada de decisão. Ele respondeu que é uma questão muito comum dele escutar, e é uma visão muito binária que as pessoas têm da posição da criança, se ela é capaz ou incapaz de compreender e de tomar uma decisão, de participar, melhor dizendo, dessa tomada de decisão. E isso é importante, o reconhecimento na forma como se trabalha com a criança, para melhorar, inclusive, né, a cooperação voluntária, que é o significado que ele deu ao assentimento, né? O mais danoso disso é a gente trabalhar, por exemplo, contra o desejo da criança. Isso não é ético, trabalhar contra o desejo da criança. E lembrar que quando a gente fala em participação da criança, não é a mesma participação que o adulto, do ponto de vista da tomada de decisão. O adulto culmina com a tomada de decisão final, que ele tem a autodeterminação, mas sim um respeito e reconhecimento da voz dessa criança nesse processo decisório. Thank you so much for your answer, Franco. It was very important, because the public we have here is the public that are the people that come from the clinical and scholarly area. And they also have this kind of a discussion when they're talking about ethical issues related to child and youth. Another thing, I think that you explore the answer of this question, but I would like to share with you is what is the limit of their wish now, the limit of the wish of children and family, and what's the limit between the wishes, children's wishes, and the security for the professional practice. I think that you explored in your presentation, but I would like to hear a little bit more about it. I'll explain the public my question. Eu perguntei a Franco, né, qual é o limite do desejo da criança, né, desse desejo da criança, das crianças e dos jovens, e qual é o limite entre esse desejo das crianças e dos jovens e a segurança para os profissionais de saúde, né, para a prática dos profissionais de saúde. Eu penso que ele já explorou um pouco disso na apresentação e eu pedi que ele desenvolvesse um pouco mais.
Well, I think the best answer I can give you is what we have learned during the pandemic. Mm-hmm. During the pandemic, children's wishes have received almost no attention at all because it has been decided in the name of safety. Everybody has to be distanced, confined, and everything was decided without their participation. The problem is the way we define safety. If we define safety only in terms of what adults think is the priority, often it's defined only in biological terms, then we don't understand the kinds of harms the children experience in other dimensions. So, for example, we found that with confinement during the pandemic, many children were profoundly disadvantaged. There may have been increased stress within the house. There may have been children with learning disabilities or language disabilities have become so far behind in their schooling. They have had complications in their socialization. So I think, yes, safety has to be always secured, but the way we define safety for a child requires a dialogue with that child to better understand all of the harms that they are facing, not just the biological ones.
Mm-hmm. Thank you. Ele respondeu que os profissionais geralmente pensam em termos de segurança relacionada à dimensão biológica, mas há outras dimensões que também podem trazer dano para a criança. E deu como exemplo a pandemia da Covid-19 com o confinamento das crianças. O confinamento afastou a criança das escolas, tirou a oportunidade de socialização, e aquelas que tinham deficiência, elas aprofundaram a deficiência, né, da linguagem, a deficiência cognitiva, né, e no caso, isso precisa ser mais equilibrado, o conceito de segurança, né, para a criança e de segurança da seguridade, né, e a segurança para o profissional. Thank you so much for your answer. I have more questions here that came after this discussion. Let me see. Mariana perguntou, is this model applied also to children who suffered any kind of violence? Did you understand the question? The model of childhood ethics, it's applied to children who suffer any kind of violence? I think that the answer is yes. Yes. Yeah.
Of course, and in fact, we are doing some very specialized work with children who are survivors and sometimes just witnesses of violence, where we are helping them develop a way to articulate their experiences so that the people around them can better understand the impacts that it has. And it also affects their moral consciousness, because when they see wrong, it can affect their feelings of justice and injustice in the world around them. And so we're doing a lot of work with children that have experienced violence, including, for example, bullying, intimidation in the schools, for example. So yes, this is of course, violence is an ethical problem, and so it is very relevant for that situation.
Violência é um problema ético, e sendo um problema ético, né, como, por exemplo, uma criança que sofre bullying na escola, né, e se ela participa desse processo, se respeita reconhece essa voz da criança, ela pode ser uma testemunha, né, do que está acontecendo com ela. Ela é a melhor testemunha do que está acontecendo com ela, além de desenvolver uma consciência moral nessa criança, de senso de justiça e injustiça. Então, o Childhood Ethics é um modelo que se aplica, sim, aos estudos da violência, e ele tem tido experiência nesse campo. Vamos à próxima. I think that we are almost at the end of this presentation and the questions answer. So I'll present the two last questions, okay? Ela explicou, deixa eu ver, Ariana Barradas, né? Ariana Barrada, em relação ao fato de, and in the situation with the child witness violence from a father toward the mothers, what is done in this situation? It's intrafamiliar violence, you know, that father and mother was in physical violence and the child is a witness. What do you think that is done in this situation? I think that she wants to know what's the role of child in the witness violence? That's the better question.
Again, what is done and what should be done. I'll tell you what should be done. Sometimes many things are not done because there's just so much, the resources are not properly adapted. But what should be done, and in some of the examples we're working in, is we work with the child following what I said before, using specific strategies. So for many, we are using writing, drawing, or photography to, we are organizing groups within the schools, for example, that are specifically focused on this. It is a program called LOVE, Leave Out Violence is what it means, LOVE, that we are affiliated with. And so we work with young people who have experienced violence to help them understand how it has affected them and to help them understand how they want to respond and react and express their needs. And it has been really, really helpful to use different kinds of media arts. So photography, drawing, writing, and at the end of the year, they organize an exposition at the school. They do a presentation on the walls of all of their art and all of their writing to bring attention to the school community, because the school community is a place that can help and can accompany young people, and you can create a more empathic environment when you take these private experiences and you have an opportunity to present them to their community.
A resposta dele é bem interessante, porque você pode criar estratégias, né? Tem um programa que eles usam lá no Canadá, que é chamado Amor e Viver Sem Violência. Então, Love and Live Without Violence, né? Nesse programa, ele participa desse programa, a escola é um lugar oportuno para se desenvolver algumas estratégias artísticas, né, mediadas pela arte, como, por exemplo, escrever, desenhar e fotografar, e as crianças ali têm a oportunidade de expressar o que ele viveu nesse ambiente de violência intradoméstica. Ao final do ano, se organiza uma exposição, e essa exposição é aberta ao público, né, da comunidade escolar, porque se pensa que essa comunidade escolar, ela vai, o que está acontecendo com a criança vai chamar a atenção da comunidade escolar. That's very interesting approach, Franco. We had experiment this kind of use of artist expression to talk about gender and peace culture in the environment of school. We are developing this project, I think, 4 or 5 years, in different schools, and more globally project with Maricela Torres. You know her?
Yes,
okay.
I know her.
Yeah.
Are you in Brazil? Is there discussion about the concept of compassionate communities?
Not yet, but
Maybe I could say a word. Maybe I could say a word about that. I know we're over time here, but
just let's explain the group, and then we explain what's compassionate care, because for following you. Eu disse para o Franco que é muito interessante e importante essa abordagem que eles desenvolvem lá no Canadá. Nós temos trabalhado com expressões artísticas como forma de mediação, né, de conteúdos, né, de aprendizagem da criança envolvida no meio social com a temática gênero, num projeto global que tem a coordenação da Maricela Torres, que ele também conhece muito bem. E aí ele perguntou se a gente tem se familiarizado com o conceito que ele vai abordar agora. Please, Franco, you have the word.
Compassionate communities is a concept that comes from palliative care. And the idea is that people who experience a death or a loss, that the most important support is not going to come from the medical system, but it's going to come from their community. And that people benefit from a community that is compassionate, that understands their needs, and can mobilize to support them. This idea is an idea we're trying to use within Voice to think of how do we build compassionate communities around children? And the school is often an important place. First of all, schools usually are a terrible place where there's a lot of violence, intimidation, and humiliation, the opposite of compassion. And so we are working with some schools to change the culture toward helping this be a place where they learn to be compassionate with each other, where they can turn on each other for a meaningful help. And the example I gave you before about the artistic exposition of experiences with violence, the motivation there is to build a compassionate community around these children.
Okay, I think that here we use the same concept, but the name is Solidarity Community. We will use this expression Solidarity Community. Okay. It was very powerful during the pandemic, especially in more vulnerable communities in Islam, because the child and poor family, they had no authority or governance enough support to continue school, and the people arrange themselves to provide an internet system to continue the homeschooling. And I think that we have the same conceptualization. I'll explain the group what did you share with us. Franco trouxe para a gente conceito de compassionate community, que aqui no Brasil a gente tem trabalhado com o conceito de comunidade solidária. Nesse conceito de compassionate community, a comunidade ela entende melhor o que está acontecendo, né, porque a pessoa vive no ambiente da comunidade, o que está acontecendo dentro daquela comunidade é capaz de dar o suporte necessário para a pessoa superar, né, as dificuldades que elas estão vivendo. E isso é mais do que só a intervenção de profissionais. Então, ao invés de fazer uma intervenção via profissional, a intervenção é feita via comunidade. Então, as escolas, elas eram consideradas, né, durante muito tempo, um espaço de violência, de intimidação, um espaço de opressão. E a ideia do Compassionate Community é fazer uma mudança desse olhar e aprender a ser mais compassionate. E isso fez com que, por exemplo, esse é o conceito que eles têm aplicado na exposição dos materiais artísticos que foram produzidos pelas crianças em relação à violência intrafamiliar, porque faz com que a comunidade se envolva e se sensibilize mais para o problema, e a escola ela tem mais condições de estar operando processos de mudança naquele espaço. Quando a gente diz a escola, ele está falando da comunidade escolar, obviamente os pais que estão frequentando essa comunidade faz parte dela. Thank you, Franco. There's other, I think that's only comments, no? Fernanda just say thanks for your brilliant presentation and relevant discussion about child as a moral agent, and the importance of hearing their voice. Her research, she's studying the inclusion of children with tracheostomy at school. In a previous search, she looked for information about this subject at the social media, and she can't see the voice of children, only the voice of families and the professor, and the teacher from the school. And in general, family and the community, family and the teacher, they don't involve the child in the decision about go to school or not go to school. Meanwhile, they have some tracheostomy. That's the reality. I think that in a country with this binary, as you said, binary conception, capable and incapable. Yeah. What do you think about this research project of Fernanda? She's a physical therapist.
Yeah, well, I think it reinforces that same point. And even in mental health, we are finding that capacity is relational. It's not binary, it's relational. And then in the way in which we explain and in the way in which we create opportunities for participation, that capacity can be improved. And I think that there's this misconception that capacity is like a fixed structure in the brain, but in fact, it is always relational. I would say it's the same for older people who might have some dementia. The way in which we communicate and we relate can facilitate expression of their capacity, or we can disable and we can compromise. We can limit their capacity.
I agree with you. Mental health, maybe we can learn more with mental health, the way they understand the capacity as a relational, not as obstacle, obstacle to believe that they are capable in some way. Franco disse que da saúde mental, o conceito de capacidade é mais relacional, né? E tem essa ideia, né, fora da saúde mental, essa ideia fixa que está estruturada na mente das pessoas, essa visão binária de capaz e incapaz, especialmente com as pessoas que têm, as crianças, né, que têm alguma incapacidade, né, ou alguma deficiência, ele é considerado como incapaz até de se relacionar, né? E aí o obstáculo é ainda maior. E eu concordei com ele, dizendo que a ideia de capaz ou incapaz acaba sendo, né, um obstáculo, essa visão binária de reconhecer a voz da criança. Franco, I think that there is one last question. I said two last, there's one more. Camille, has one question for you. Okay, Camille said, in the case in the girl with end-stage cancer, I think it's really important to listen to the child's voice. Children need to be involved in the decision making that affect them. It's just a comment, it's not a question. And you said it, It's
I think
just a confirmation.
Camille and I see things the same way.
Yeah, and they learn a lot in the childhood voice, and she learns a lot. She learned a lot. Franco, thank you very much for your time and stay with us until now. Your generosity. I know that you are very, very, how can I say, you're very busy now. The situation around the world is still very hard, here in Brazil, in Canada, and everywhere. So I know that your time is very precious, and thank you so much for sharing your time with us. You are a very generous person.
I'm honored. Thank you so much.
Ok, agradeci a Franco, né, pelo compartilhamento da apresentação dele e a exposição, a generosidade, sabendo que nesse momento ele está muito envolvido, né, com a pandemia também no Canadá, como consultor clínico, e ter reservado um tempo para estar conosco. Então, muito obrigada, e muito obrigada a participação de todas, lembrando que a próxima apresentação, né, da próxima mesa já está registrada ali no YouTube, dê uma olhada, o link para assistir a próxima apresentação. Franco, see you next time. I hope that the next time will be in presence. Okay?
I hope so too.
Bye-bye.
Okay. Ciao, ciao.
Tchau, tchau.